So Aisha Mustapha is one of our current cardiology fellows. She did her internal medicine training at Johns Hopkins, and we were luckily able to recruit her here as a vascular medicine fellow last year. She's currently doing a research fellowship in the area of peripheral vascular disease, and then we'll have 2 more clinical cardiology years. And after that, we'll see what the future has in store. But she's very bright, energetic, enthusiastic, very smart, and she's going to teach us everything we need to know about management of spontaneous coronary dissection. Thanks for being here.
Thank you.
Did I miss anything?
I don't think so.
Okay.
Yes. Hello, everyone. As Dr. Walls mentioned, my name is Aisha Mustapha, and I'm currently a cardiovascular disease fellow in my research here at Emory. So I'll be talking to you guys today about SCAD treatment, or spontaneous coronary artery dissection treatment. And I didn't include a disclosure slide because it really does not matter for me at all. So just a brief outline here of what we'll be discussing. I'll talk about acute management after SCAD diagnosis. I'll talk about management after discharge, as well as what happens during your first few outpatient clinic visits after discharge. Then we'll talk about long-term management, and I'll touch on activity restrictions, which I think someone has already asked a question about. So starting with acute management, the goal here is to restore and preserve myocardial perfusion, or blood flow to the heart, as well as cardiac function. And the big takeaway here is that we aim for management to be as conservative as possible. And so, when a person comes in with chest pain, which, as you've heard, is a common presenting symptom for SCAD as well, we're worried about common things being common. And so the concern at that time is typically for acute coronary syndrome or heart attack that's caused by an atherosclerotic plaque rupture, which is the fatty plaque rupture that causes most heart attacks. And so a lot of what we do as treatment is a response to this concern. But when we have a SCAD diagnosis, and when we've confirmed a SCAD diagnosis, we typically try to pull back on some of these therapies as long as the patient is stable. So here are some things that we typically do as part of our treatment for SCAD, and things that we avoid once we know that the person has SCAD. So the first thing in our do's bucket is beta blockade. Beta blockers are medicines I'm sure a lot of you in this room have heard about, such as metoprolol or carvedilol. How they work is that they decrease the heart rate, they decrease the force of contraction of the heart, and that typically leads to lowering of blood pressure. We know that they are successful in aortic dissection to reduce arterial shear stress for a lot of the reasons I just mentioned, and so we've sort of extrapolated that to treatment for SCAD patients. The second medicine that's in our bucket is aspirin. So we know that aspirin is a blood thinner, it's an antiplatelet medication, and we typically use aspirin therapy, monotherapy, as part of our conservative management. But there are situations where patients will be on what we call DAPT, or dual antiplatelet therapy, and this is typically a combination of aspirin and another blood thinner or antiplatelet medication called a P2Y12 inhibitor, like clopidogrel or ticagrelor. And the most common scenario where a patient is on DAPT is if they've received a stent as part of their SCAD treatment, which we'll talk about more in detail. And then lastly, we make sure that once SCAD diagnosis is made, that the patient is monitored in the hospital for at least 3 to 5 days to make sure that they don't have any repeat symptoms or recurrence. And so in the don'ts bucket, I think the first thing that we avoid, big X, is what we call thrombolytics. These are essentially clot buster medications. They're systemic medicines that we give through IVs, and they're used in other medical scenarios, in some heart attack as well as stroke scenarios. What we know is that they're not good in SCAD patients because they cause worsening, extension of the dissection. They also cause bleeding or hematoma, which is extension of that blood clot that can form with SCAD. Similar with anticoagulation, these are also blood thinner medicines that work similar to antiplatelets, but slightly different mechanism. And we know that they can also cause extension of dissection and bleeding. So if a patient doesn't have any other reason why they're receiving anticoagulation, it's not something that we start when there's a SCAD diagnosis. And then thirdly is percutaneous coronary intervention, or PCI, which I mentioned earlier. These are basically stents used to treat blockages in the coronary arteries. We know that PCI is associated with worse outcomes, high complication rates, by causing dissections themselves. So you can imagine a very fragile vessel, putting a stent in that can cause trauma and extend the tear or dissection, can cause the blood clots to go further in the vessels, causing more blockage. In some cases, you can also stent the false lumen. So as Dr. Oleko mentioned, there is this flap that forms, there's a true lumen, which actually provides blood flow. A false lumen does not provide blood flow. When you stent the false lumen, imagine that you're narrowing the true lumen, which actually is providing blood flow. So we typically do not want that. And lastly, lipid-lowering therapy. Dr. Wells mentioned this for FMD. We also do not have any proven connection between cholesterol and SCAD. So if the patient does not have any traditional reasons why they would be on a statin, like a atorvastatin or a suvastatin, like coronary artery disease or diabetes, for example, we do not start statins after an FMD, after a SCAD diagnosis is made. Okay. Let me just do this. Can everyone hear me? Okay. So again, I mentioned conservative management. I think the big thing here is we try to be as conservative as possible, because a lot of patients, up to 95% of patients who have SCAD will show angiographic healing up to 30 days after their event. So again, we try to let things be and let patients heal on their own. There are cases where restoring blood flow to the heart with a stent or bypass surgery is necessary, and some of these cases I've listed here. The first one is a left main coronary artery dissection. The left main coronary artery is one of the major arteries that leads to different vessels that supplies the heart, and when a patient presents with dissection or SCAD in the left main coronary artery, they typically present more severely, and so in this case, they might need further procedures to restore blood flow to the heart. Same thing with ongoing ischemia. This just means that there is less blood supply to the heart. Hemodynamic instability, the patient has low blood pressure, is requiring further therapies and drugs to keep their blood pressure up, and refractory arrhythmias. These are just dangerous blood rhythms, heart rhythms, typically in the ventricles, that again is a response to lack of blood flow to the heart. And so in these cases, we might need revascularization with a stent or bypass surgery to sort of restore that blood flow. I do want to emphasize here that neither a stent nor bypass surgery is protective against recurrent SCAD. So doing all those procedures and kind of messing around in there isn't going to prevent SCAD from recurring if that's something that's going to happen. So again, this is just a summary of everything we discussed. If the patient is diagnosed with SCAD and clinically stable with no high-risk anatomy involved, such as the left main coronary artery, as I mentioned, we do conservative therapy, again, aspirin, beta blockers, and monitor them in the hospital for any recurrence. If the patient is clinically stable but has the left main coronary artery involved or more than one coronary arteries, we can consider CABG. And then if the patient is very unstable, in some of those situations, we would do a stent or urgent bypass surgery if the hospital is able to do that. So what happens in the clinic visit after SCAD? That's when we really sort of dig into potentially how the patient presented, what made them go to the hospital, how they were diagnosed in the hospital. So we typically review the coronary angiogram at that time and confirm that we see SCAD and we know the vessels that are involved. We talk about how they were managed in the hospital, whether or not they were conservatively managed or got stents or bypass. We talk about potential triggers. So this isn't typically asked in the hospital as detailed as we might go into in the clinic visit. So we try to drill down on whether there was a specific emotional trigger or physical stressor, if the patient was pregnant or in their postpartum state, that is important as well. We talk about certain medications or illicit drugs like cocaine or amphetamines that may have been a trigger. We dig into the personal medical history, including history of prior SCAD or traditional heart attack. We talk about whether or not they have underlying heart conditions, fibromuscular dysplasia or any connective tissue disease, migraine, and importantly for females, pregnancies. We know, again, that multiparity or multiple pregnancies potentially is a risk factor, infertility treatment, whether or not they've received IVF, and then sex hormones. We talk about family history and social history. I think the big thing, our takeaway for post-discharge management is we make sure that the patient is screened for fibromuscular dysplasia, as has been mentioned in the past. So head to pelvis CT angiogram or MR angiogram is typically how we screen patients to look for FMD. We know that approximately 50% or more patients with SCAD will also have underlying FMD, and so this is our priority. In our post-discharge visits, we make sure that the patient has heard about, has been enrolled, or at least referred to cardiac rehab. For a lot of these patients, the target heart rate is approximately 75% of what we calculate as their maximum predicted heart rate, and this is different for everyone based on their age. We make sure that patients understand to avoid isometric exercise and heavy lifting. These sorts of exercises cause static contraction of large muscle groups. As you can imagine, the blood pressure acutely increases, and it has to be sustained because you're straining, and this causes a lot of stress on the heart. We make sure that patients avoid stimulant medicine, exogenous hormones. I put an asterisk next to this because a lot of patients might be on hormone replacement therapy for certain symptoms and may not be able to discontinue the hormones. And in this case, we advise as low as possible to manage their symptoms. We talk about pregnancy and contraception. We treat recurrent chest pain and also refer patients to mental health services if needed. There's a lot of anxiety and depression after a SCAD diagnosis that a lot of patients can experience, and we want to make sure that they're well taken care of. A word on cardiac rehab. The big takeaway here is that all SCAD patients should be referred to cardiac rehab, whether or not they're young and relatively healthy. And we know that cardiac rehab is not as utilized as we would like after a SCAD diagnosis. There may be some concerns about the safety of cardiac rehab, given that physical activity can be a trigger for SCAD, but we know that it has great long-term and short-term benefits. A lot of people might be very physically active before their SCAD diagnosis and might be very fearful of getting back into that, and cardiac rehab is a very safe way of getting them back to their baseline physical activity. We know that it helps with chest pain, psychosocial well-being. I think more importantly, we know that it is safe, and so patients need to be enrolled and take advantage of this. A lot of programs, again, will aim for a heart rate between 50 and 75% of the patient's maximal heart rate, and the format typically is 3 sessions a week of exercise, starting about 20 to 30 minutes per session, and then ramping up to 60 minutes as patients get more comfortable. And then long-term management, the goal is really a continuation of what we do post-discharge. And so if a patient is diagnosed with FMD based on screening, we make sure that they're getting surveillance, typically with a duplex ultrasound of the arterial beds that are affected. We want to keep monitoring for chest pain and SCAD recurrence. With recurrent chest pain, there's no way to tell which patients will get recurrent chest pain, but it is common. It can happen early after SCAD diagnosis and can also last for many months. The mechanism is thought to be due to coronary microvascular dysfunction. There is a prospective study from a Canadian SCAD cohort that has shown that men have lower rates of chest pain, short-term, long-term follow-up. Men also have lower rates of emergency visits and hospitalization due to chest pain compared to women, but we really don't know why that is. And the focus, again, should be on blood pressure control, use of medications to increase blood flow to the heart, decrease stress on the heart, like beta blockers and nitrates. A word on SCAD recurrence. As Dr. Laleko mentioned, recurrent rates have been quoted to be as high as 20 to 25% in 5 years, which sounds like a lot. But again, we have this recent outcome study showing the Canadian SCAD cohort. So these are patients diagnosed with SCAD and then followed so far for 3 years, but we're probably going to get 5-year and 10-year outcomes. What we found is that recurrent heart attacks in these patients occur about 9.9% in 3 years. 3.5% of that is an extension or worsening of their previous SCAD. 2.4% of that is new SCAD in a different vessel, and 1.9% is iatrogenic. We also know that overall, the MACE, or major adverse cardiac events, in these patients was 14% in 3 years. And you see here, this is the diagram illustrating this. A lot of those events actually happen within 14 days of SCAD diagnosis, and less after that. And so I think this further reinforces that we need to really watch patients after they're diagnosed with SCAD. And I think this is great news, is that mortality was only 0.8%, which we want that to be 0%, but 0.8% in 3 years, I think, is pretty remarkable. And again, we know that hypertension increases the risk of recurrence, so we want to manage that. There is one study, again, by the Canadian group that has shown that beta blockers might reduce the risk of recurrence. So we see here in that cohort, patients who received beta blockers had less recurrent than patients who didn't receive beta blockers. We do have a randomized control trial that's in the works right now. It's called the beta blocker and antiplatelet for SCAD patients randomized trial, and so we're hoping to get more information from this. And then lastly, activity restrictions. We want patients to avoid extreme endurance and resistance training, strength training with heavy weights. It's hard individually to put weight limits, but again, generally it's greater than 50 pounds for males and greater than 30 pounds for females. We advise that patients do not exercise to exhaustion, competitive sports, no rugby or football, if you're so inclined after your SCAD diagnosis. We advise that patients don't exercise in extreme temperature, and then heavy lifting sometimes can lead to Valsalva, which is straining again and bearing down and holding your breath. A lot of this causes blood pressure to increase quickly and stay up, and that again causes stress on the heart. We do recommend cardiac rehab, as I recommended, moderate aerobic exercise. So Zumba is great. Thinking about those heart rate sort of limits I mentioned. So 75% of maximum heart rate is pretty high. A lot of people typically just in the regular exercise probably are not going to get there, except they're doing competitive sports or extreme exercises. So as long as you can do Zumba or spin or whatever and keep to those heart rate limits, you're good. Interval training is great because you're exercising and then resting, and so there isn't a sustained blood pressure or heart rate increase, and there's typically time for rest. And again, that reduces stress on the heart. And then lastly, weight or strength training with low weights, low resistance, and high repetition is what we recommend. And then I will stop there and take questions.